I think HER2 inhibition will be very important in lung cancer, but only in the subpopulations which carry HER2-driven lung cancers. And there are a very select subgroup. We know that HER2 mutations are activating and can drive lung cancer. We know that from multiple different in vitro and in vivo models. We also know that some of the pan-HER inhibitors can have activity in HER2 mutant lung cancer, and that's certainly being explored in ongoing clinical trials. Whether HER2-directed antibodies will have the same activity in HER2 mutations is, I think, not yet clear, but there's also HER2 amplification that occurs in non-small cell lung cancer. Again, at a very small rate, both HER2 mutation and HER2 amplification are thought to occur in around the 2% range of all lung cancer. And whether they are overlapping populations or not is also still being debated. Some studies have found that they're mutually exclusive, and others have found that there is overlap between mutation and amplification. Amplification may or may not have the same implications for overexpression that it does in breast cancer. So I think that's still really an open question. However, HER2 amplification is certainly a pathway to oncogene-addicted cancers. In breast cancer, that's clearly been shown. HER2 mutation has clearly been shown to be an oncogenic driver in lung cancer. So we know those are targetable areas, and therefore HER2 inhibition definitely is going to have a role to play. I think the trick now is sorting out which drugs for which HER2 changes is most appropriate is still not yet clear. There are 3 different drugs that have been looked at directly in HER2 mutant lung cancer. One was afatinib, which was not a separate study for HER2 mutant lung cancer, but there was a cohort and an ongoing larger study which used afatinib and then added paclitaxel at the time of progression. There were very few patients treated on that study, only a handful, but some of them did have responses to single-agent afatinib, although they were short-lived. Some of those had more durable responses once paclitaxel was added. Dacanitamab also had a larger study with a cohort dedicated to HER2 mutant lung cancer, and again saw a response rate that was respectable, although not the kind of response rate we've seen with EGFR inhibitors against EGFR mutant lung cancer. The responses were quite limited. Because of that, it's not clear, at least to me, whether HER2 pathway activation and HER2 inhibition is going to be the same as something like EGFR inhibition or ALK inhibition in lung cancer. And it may require either more potent drugs or something more than the HER2 drug itself. There's been abundant preclinical data in both breast cancer and lung cancer that combining downstream inhibition with HER2 inhibition, such as mTOR inhibition, can result in synergistic responses. We conducted a phase 1 trial of neratinib plus temsirolimus in all cancers, but there were a small subset of patients with HER2 mutant lung cancer treated on that trial. 5 of 6 evaluable patients on that study had some amount of tumor regression, and that led to a phase 2 study that's ongoing right now, dedicated in HER2 mutant lung cancer. It's a 2-arm study of neratinib plus temsirolimus, because we don't actually know the single agent activity of neratinib against HER2 mutant lung cancer. It has been tested in lung cancer, again in an unselected population where we didn't really see much. So what we really need to know is how well does that HER2 drug work in the right population, the patients that have HER2 mutations. So that's being evaluated now in that ongoing study, and hopefully from that we'll learn what are the right drugs to be using in that population.